Greetings. Today we are going to discuss about HIV and AIDS. The contents of the lecture would be regarding history, HIV/AIDS scenario, virology, mode of transmission, immunopathogenesis, natural history, clinical staging, mucocutaneous manifestations, lab diagnosis, the antiretroviral treatment, immune reconstitution, inflammatory syndromes, post-exposure prophylaxis, preventions. Now the AIDS history. In 1981, first case was diagnosed by Joel D. Wiesman and Michael S. Gottlieb in homosexuals in San Francisco, USA, presented with Kaposi sarcoma and pneumocystis carinii pneumonia. In 83, a positive organism was isolated in a laboratory in France. In 84, Robert Gallo in United States of America coined the term human T-cell lymphotropic or lymphopathic virus, HTLV-3. In 86, International Community of Taxonomy called it human immunodeficiency virus. Now, this is the history of AIDS in India. In 86, first case was diagnosed in India. In 87, first antiretroviral drug was used, azithromycin. In 89, compulsory testing for blood for HIV was started. In 95, availability of protease inhibitors, beginning of highly active antiretroviral therapy, HARD, was initiated. In 2017, introduction of test and treat policy by National AIDS Control Organization was initiated, whereas initiation of antiretroviral therapy free of cost once the person is detected HIV positive. Why is it a hazard to humankind? First of all, it's the major mode of transmission is sexual. Sexual urge is of physical intimacy is a fundamental in all human beings. Mother to child transmissions also take place. There is a long incubation period. People with no knowledge of being infected can infect others unwillingly. Um, as far as cure is concerned, in antiretroviral therapy era, chronic manageable disease with lifelong medications pose a lot of challenges. And we are at this stage at the moment, which is AIDS has become a chronic manageable disease. Prevention depends upon following self-protective sexual behavior code and one which protect other. It is very challenging to change human behavior, and preventive vaccine is not yet available. Now, the current scenario of 2020 is people living with HIV are 37.7 million. Adults and children newly infected with HIV are 1.5 million. AIDS-related deaths among adult and children is 0.68 million. People infected with HIV since the start of epidemic are 79.3 millions, which is a range which is somewhere in between 55.5 to 110 million. People died from AIDS-related illness since the start of epidemic is approximately 36.3 million. People having access to ART are 26.5 million to 27.7 million. It's a range. This data was given by United Nations AIDS report on global AIDS epidemic 2021. Now, the epidemic in India, estimated people living with HIV at the end of 2019 are 23.48 lakh. Estimated adult HIV prevalence in 2019 is 0.22%. Estimated people newly infected with HIV in 2019 is 69.22 thousand. And AIDS-related death in year 2019 is 58.9 thousand. Human immunodeficiency virus. It belongs to the family Retroviridae genus lentivirus, the genus of slow viruses with long incubation period. It's a retrovirus, though it is a RNA virus. For its multiplication, RNA is converted into DNA with the help of enzyme reverse transcriptase. The origin of HIV, scientists identify a type of chimpanzee in West Africa as the source of HIV infections in human. Chimpanzee version of immunodeficiency virus is called simian immunodeficiency virus or SIV. most likely was transmitted to humans and mutated into HIV when humans hunted these chimpanzees for meat and came in contact with their infected blood. So this is the chimpanzee, this is the Sooty Magabe, another monkey. Over the decades, the virus has slowly spread across from Africa later into other parts of the world. Now, this is the structure of the virus. In the core, you can see there is polymerase, reverse transcriptase, and the genetic material RNA, two molecules of it. And then there is capsid, the matrix material, the envelope made up of glycoproteins GP41 and 120. Types of HIV has been divided into two types, one and two. One is the major cause of disease all over the world. 11 subtypes are present of type 1, A, B, C, D, E, F, uh, so on and so forth till K. Subtype C is most prevalent in India. HIV-1 subtype C is associated with sexual transmission. Subtype D is mostly associated with intravenous drug abusers and homosexuals. HIV-2 is restricted to certain geographic areas like West Africa, and transmissibility, lesser, longer incubation periods, and better diagnosis uh, than the more virulent HIV-1 form. So HIV-2 is less transmissible, has a longer incubation period, and a better prognosis. HIV-2 is intrinsically resistant to most NNRTIs. Now, circulating recombinant forms. Occasionally, two virus subtypes can infect the same person, and a recombination process can take place, uh, which may be transmitted into the population. Now, the entry and replication. The receptor binding takes place between a CD4 receptor and CCR5 and CXCR4, along with it, a virus's glycoproteins. It uncoats the genetic material and the enzymes. Reverse transcriptase forms DNA from RNA. Integration of the genetic material takes place into the genome of the cell, which is called as provirus. It, by methods of transcription and translation, viral RNA is formed, which translates viral proteins. The assembly takes place. The budding of the virus occurs from the surface of the cell, and then in the stage of maturation it departs and infects the other cells. The peculiarities of HIV: heterogeneous and genetically diverse in variety of biological and serologic and molecular features. Predominantly it is lymphotrophic to CD4 helper cells. The incurability is due to most characteristic feature which has been attributed to its persistent in sanctuary or reservoir sites. A majority of them being the resting memory CD4 T cells, which have long half-lives and are unaffected by antiretroviral therapy. It evades the immune response. It is highly mutagenic, and replication is error-prone, leading to drug resistance and difficulty in preparation of its vaccines. Now, there are body fluids which are contaminated with HIV, then there are body fluids with no or low concentrations of HIV, or we can say which are not contaminated by HIV. So it is very important to remember which are not contaminated by HIV. It also stops the stigma uh, from spreading and the fear of HIV. So saliva usually does not transmit. Tears, sweat, urine, stool, they do not transmit the HIV virus. Whereas blood, semen, vaginal secretions, breast milk, amniotic fluid, CSF, pleural, pericardial, any serous fluid or any body fluid contaminated with blood contains HIV. So it is very important for us to know this. Now, the modes of transmission: when HIV infected, body fluids come in contact with uninfected person by different routes. First is sexual, and it may be through blood. It can be due to using the same needle or using the same blood product. Then to child transmission or vertical transmission also takes place. The chances of male to female transmission is 5 to 6 times higher. The reproductive tract infections are common in women. Presence of STDs makes it more likely to cause the spread because of inflammation and microabrasions due to persisting STD. Receptive anal intercourse has the highest risk of transmission because rectal mucosa is more fragile and there are greater chances of injury. Now, the routes of transmission are explained through a pie chart. Most common is heterosexual 88.2. Now, the exposure route and the efficacy. Blood transfusion has the efficiency of transmission on highest as 90 to 95%. But if we see the sexual route, the vaginal intercourse has 0.05 to 1%, and the others are enlisted in the table. Now, immunopathogenesis. Immune system of a human body comprises of cell-mediated immunity, which is governed by T cell, and humoral immunity, which is governed by antibodies produced by B cells. Two types of T cells are important in immunopathogenesis of HIV, which is helper T cells and suppressor T cells. The killing of CD4 lymphocytes results in marked immunosuppression. And which leads to opportunistic infections caused by commensals and environmental contamination and non-pathogen as well as malignancies associated with suppressed immunity. Now, the cells bearing CD4 receptors and thereby susceptible to HIV are present on skin, nerves, hematopoietic cells, and the others like colon carcinoma cell, gut-associated lymphoid tissue, retinal cell, placental, trophoblast, etc. Natural history of HIV infection is from the point of entry of HIV infection, you don't see the antibody levels immediately. The antibodies start to appear after 4 to 8 weeks period. So that period of 4 to 8 weeks from the entry and the appearance of antibodies against the HIV virus is called the window period. So in window period, it is not possible to detect HIV by antibody related methods. The viral load increases and it reduces because of the presence of antibodies at the end of the window period. The CD4 cell count slowly reduces as the disease progresses. This is another chart signifying the and depicting the same thing. Okay. So stages of HIV infection. Primary infection, there is seroconversion illness. When person becomes HIV positive, there are 4 clinical stages beyond that. Stage 1, where CD4 count is more than 500, where patient is asymptomatic, might suffer from persistent generalized lymphadenopathy. When the CD4 count is 200 to 500 in stage 2, there is unexplained significant weight loss, and herpes zoster is seen in this stage. Below 200 CD4 count is stage 3, where there is unexplained weight loss, diarrhea, and fever. And when the CD4 count drops below 50, stage 4, the age-defining opportunistic infections and malignancies start to appear. So this is again explaining the same thing about clinical staging in much more detailed way. Opportunistic infections. Infections in immune-compromised patients caused by microorganisms usually not pathogenic to a normal immune system. It can be due to commensals or environmental contaminants or even non-pathogens which do not cause illness. So, HIV-related infections most frequently encountered in India are causative organisms. They can be bacterial, viral, fungal, protozoal, and other illnesses. So bacterial is tuberculosis and syphilis. Salmonella infections affecting GIT, tuberculosis and syphilis affecting CNS. Tuberculosis bacteria respiratory infection like Mycobacterium avium complex affect lung. Mucocutaneous bacterial infections like bacillary angiomatosis and pyoderma in children. Similarly, Virus that affects CNS is cytomegalovirus, lungs CMV pneumonia again, and mucocutaneous are herpes simplex viruses, oral hairy leukoplegia, varicella zoster infections, molluscum virus, human lymphoma, uh, human papilloma virus, HPV infection. CNS affecting fungus is mostly cryptococcosis, in GIT candidiasis, in lungs pneumocystis, Jerovicki pneumonia, and mucocutaneous by oral candidiasis. And others like penicilliosis also takes place. In protozoa, toxoplasmosis affects CNS, cryptosporidiosis, giardiasis, strongyloids, and microsporidiosis, and isosporiasis, and amoeba histolytica affect the eye. Other illnesses like AIDS, dementia complex, progressive multifocal leukoencephalopathy also takes place. Non-Hodgkin lymphoma, and invasive cervical cancer. So this is the graph which is plotted between time and CD4 count, and as the CD4 count drops, the opportunistic infections creep in and start to set in. Now, mucocutaneous manifestations of HIV infections. Skin is the most commonly affected organs in patients with HIV/AIDS, with more than 90% of HIV-infected patients developing mucocutaneous signs and symptoms. Cutaneous manifestations can occur through all stages of HIV infection. Skin manifestations have diagnostic and prognostic significance, as with different HIV viral load, CD4 count, manifestations differ. It is helpful in situations where facilities of CD4 count and viral loads are not easily available to monitor the progression. The skin, perpetual skin, mucosa contains a lot of CD4 receptor bearing cells like Langerhans cells and fibroblasts. Classification of mucocutaneous manifestations: it can be either infectious, non-infectious, specific mucosal manifestation, nail and hair cutaneous ADR due to antiretroviral therapy, such as morbilliform rash, urticaria, angioedema, Stevens-Johnson syndrome, or even toxic epidermal necrolysis. These are the viral, bacterial, fungal, and parasitic infections which are present in mucocutaneous manifestations. Some of them are acute exanthema of HIV, herpes simplex, Epstein-Barr virus, HPV, molluscum, and Kaposi sarcoma. In bacterial infections, staphylococcal, mycobacterial, and bacillary angiomatosis. In fungal, like dermatophytosis, candidiasis, malassezia furfur, deep and systemic mycosis, cryptococcosis, histoplasmosis, and penicillinosis. In parasitic infections, arthropod infections, scabies, and hemodicidosis. Protozoal infections like pneumocystosis, toxoplasmosis, and leishmaniasis. Now, non-infection manifestation can be either dryness, eczema, seborrheic dermatitis, psoriasis, papillopruritic eruptions, pruritus in HIV, pigmentary disorders, cutaneous adverse reactions, and neoplasm. Specific mucosal manifestations include abnormal mucosal pigmentation, oral ulceration, viral infections like oral hairy leukoplegia, HSV, herpes zoster, HPV, fungal infections like oral candidiasis, malignancies like Kaposi sarcoma, and non-Hodgkin lymphoma. Nail and hair manifestations. In nail, usually onychomycosis, yellowish discoloration, melanotic band, black pigmentation due to zidovudine is seen if you are giving zidovudine. Hair manifestations are usually premature graying of hair, diffuse hair loss, male patterned alopecia, alopecia areata, and long eyelashes. Herpes simplex virus. Herpes, as we all know, HSV1 causes orolabial erosions and HSV2 causes genital lesions. HSV, HIV is a double trouble. So transmitters can either transmit each other. This is the picture representing extensive herpes labialis. It appears as a tender, often painful, and giant ulcerative lesion on genital region. Perianal area, lip are the hallmark of HSV in HIV infected patients. As the immunodeficiency progresses, HIV HSV infections become more chronic, persistent, progressive, recurrent, responding less promptly to oral antiviral treatment. Now, the treatment includes administration of 400 milligrams of acyclovir 3 times a day till there is complete healing. So, in herpes labialis, we can also see there is herpes progenitalis, pre-treatment and post-treatment, which is in which we have given acyclovir. Now, herpes zoster in AIDS, it is caused by varicella zoster virus. So, when there is immunosuppression, so usually herpes zoster appears in people with older age groups, but here it would appear in younger people with recurrences, with hemorrhage, hemorrhagic lesions, dissemination, and multi-dermatomal involvement. The treatment is oral acyclovir 800 mg 5 times a day till there is complete healing. Now, there is no defined limit for time here till there is complete healing. Valcyclovir is also preferred, which is 100 milligrams or 1 gram twice a day. Preferably, it should be started within 48 to 72 hours after appearing of rash. This is herpes zoster ophthalmicus and multidermatomal herpes zoster represented in pictures. Severe chickenpox in HIV positive children can also take place, herpes zoster, and these are the scars of herpes zoster. Now, molluscum contagiosum virus, that is a DNA virus belonging to Poxviridae family. Clinical features are umbilicated pearly white papules. In HIV, the lesion tend to be more numerous, white-sided, nodular, and disfiguring. Extragenital giant molluscum are a marker of AIDS. Now, treatment is by ART, which is very effective and additional with conventional methods like cryotherapy, electrodesiccation, and dental curettage. Kaposi sarcoma. The etiology is human herpes virus 8. Mode of transmission is transmitted sexually, probably more by fecal-oral route or ejaculate rather than by blood in HIV and in homosexual men. The classical lesion is a purple patch, plaque, or nodule which may ulcerate. Aggressive course in HIV, especially amongst homosexuals, and the treatment is good but unpredictable when given ART. Specific local or systemic therapies is often instituted as well. Now, HPV, human papilloma virus, these are cutaneous and inogenital warts. Inogenital warts are called condyloma acuminata, caused by HPV infection. They can be extensive, numerous, and resistant to therapy when a person has HIV. HPV 16 and 18 are associated with carcinoma in situ cervix, vagina, and rectum, and high-grade dysplasia. Invasive cervical cancer is aggressive in nature and is an AIDS-defining condition. Treatment is by topical imiquimod, podophylline, liquid nitrogen, cidofovir. ART can lead to decrease in its size. So these are the genital warts and oral hairy leukoplakia present. Now, bacterial infections can be by various etiological factors. Staphylococcus aureus is most common bacteriological pathogen causing cutaneous and systemic infections in HIV. Primary staphylococcal infection in HIV is presented via bullous impetigo, eczema, staphylococcal skin scald syndrome, folliculitis, furunculosis, carbuncles, cellulitis, and hidradenitis. Bacillary angiomatosis is a vascular proliferative response to infections with gram-negative cat scratch organism, Bartonella hensleri and Bartonella quintana. Usually occurs when CD4 count is less than 200. It is solitary or multiple small red papules, pinpoint-sized papules that increase in size to form nodules and tumors. Now, the diagnosis is by H&E staining and Warthin starry staining. Drug of choice is erythromycin. 500 milligram 4 times a day is given for 3 to 4 weeks. Cutaneous tuberculosis, it has diverse clinical presentation. Scrofuloderma, scattered violaceous papules, keratotic papules, and nodules, tuberculate. Clinical appearance is not usually characteristic most of the times because the immune system is not uh, normal in HIV patients. There is immune suppression, so clinical presentations may vary. Always suspect TB in a non-healing cutaneous ulcer, not responding to antibacterial or antiviral. Fungal infections like candidiasis takes place. Oropharyngeal candidiasis is the most frequent opportunistic fungal infections affecting 90% of the HIV patients at some point during their progression of disease. Now, candidiasis can be oropharyngeal, esophageal, vulvovaginal. The organism causing is Candida albicans. The clinical features appear as cottage cheese like creamy white exudate plaques on tongue, which can be easily removed and leaves an inflammatory erythematous surface. Treatment is by fluconazole 100 mg daily for 14 days. And oropharyngeal candidiasis is an AIDS-defining illness. Again, oropharyngeal candidiasis with angular cheilitis, cottage cheese, creamy white exudative plaque on the tongue, and esophageal candidiasis. Now, dermatophytosis. In usual cases, it is less extensive, less varied, and typical. In people with HIV, it is varied, extensive, and atypical due to immune suppression. The treatment is systemic antifungals like itraconazole, fluconazole, terbinafine with topical azoles like clotrimazole, sertaconazole, and doliconazole. Now, parasitic infections like scabies are more severe at lower CD4 counts. Usually, there are 10 to 15 mites affecting a single adult individual, but in this case, millions of mites would affect this immune compromised person and would manifest as crusted scabies or called as Norwegian scabies. The treatment is scabicides like permethrin and GBHC along with single dose of oral ivermectin. Now, non-infectious dermatosis and papular and follicular eruptions. The papules are transient of 4 to 6 weeks. When they cross the 6-week line, it is called as chronic. So chronic papulofollicular, and it can be follicular, and others like pruritus, prurigo nodularis, and insect bite reaction. These are the non-infectious dermatosis, papular and follicular eruptions. Now for lab diagnosis, we do specific antibody detection test by ELISA and confirm it by Western blotting. So the window period is 3 weeks to 6 months. The rapid test is recommended. Western blot is confirmatory test and highly specific. So the P4 antigen detection, the window period is very small. So you can start detecting P4 antigen and reverse transcriptase assay after the entry of after 7 days or 10 days after the entry of virus. These are also highly specific and sensitive, but low sensitivity. Now, 4th generation ELISA starts detecting the virus from 16th day onwards. The 4th generation ELISA detects P24 antigen and antibodies and reduces the window period, which is beneficial for us. The detection of viral nucleic acid starts detecting from 7 to 10 days, where we use PCR tests or nucleic acid amplification tests or NAT. These are highly specific and sensitive. It is useful in diagnosing pediatric HIV of patients with age less than 18 months. And isolation and viral culture reports take time. It is not feasible and used in research settings only. Prerequisites for HIV testing, the 3 C's: consent, informed consent should be taken, counseling, pre-testing counseling, and confidentiality. So the report should only be shared with the patient and should be kept confidential, should not be public. So the post-testing counseling is also very important. If it is positive, the patient is referred to ART center. If negative, the subject is counseled regarding the reduction of high-risk sexual behavior. Laboratory monitoring and immune deterioration and prognosis. So the CD4 lymphocyte count is the most important marker of immunologic status in HIV positive patient. The level of CD4 correlates with the occurrence of opportunistic infections, and the plasma viral load and detects exact quantity of virus in plasma. Best measured by branch DNA signaling amplification assays. Other techniques like RT-PCR and nucleic acid sequence based amplification can also be used. Plasma viral load and CD4 count are the most important predictors of progression to AIDS and the prognostic markers of HIV and response to ART as well. The combination of antiretroviral therapy, what are the goals of it? So the clinical goal is prolongation of life, improvement of quality of life. Virological goals is maximal and durable suppression of viral loads to keep it less than 50 copies per ml so as to halt the disease progression. And immunologic goal is to preserve the immune system. Recovery of immune system, the quantitative or normal CD4 count and qualitative pathogen specific immune response, immune reconstitution. So the recovery of immune system should also be quantitative and qualitative. The count should be normal, and the person's immune system should respond accordingly. Therapeutic goal is rational sequencing to maintain therapeutic options relatively free of side effects, realistic in terms of adherence. Epidemiological goals is to reduce HIV transmission, test and treat policy. This renders patient non-infectious. Plasma viral load becomes undetectable within 6 months of starting ART, which is good. If HIV plasma viral load is undetectable, HIV becomes untransmissible. This diagram represents various modes of action of antiretroviral drug. Some are fusion inhibitors, others inhibit reverse transcriptase, some are integration inhibitors, some are protease inhibitors, and they have all their different kinds of action. Some are receptive binding, inhibit receptive binding. We'll study them in detail. So classes of drug available are nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, fusion inhibitors. There is nucleotide reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, and HIV entry inhibitors. So they block CCR5, which is maraviroc. So nucleoside reverse transcriptase inhibitors are zidovudine, lamivudine, abacavir, emtricitabine. They are also represented in the brackets by their codes. Zidovudine is AZD, lamivudine is 3TC, abacavir is ABC, emtricitabine is FTC. Non-nucleoside reverse transcriptase inhibitors are nevirapine, efavirenz, delavirdine, rilpivirine, and itravirine. Fusion inhibitors are enfuvirtide. Nucleotide reverse transcriptase inhibitors are tenofovir. There is nucleotide and there is tenofovir. So there is T and T in the drug as well. You can remember it by that. Protease inhibitors are either boosted PIs like lopinavir, ritonavir, atazanavir, and ritonavir, and darunavir. Integrase inhibitors like dolutegravir, alitegravir, and dolutegravir. CCR5 entry inhibitors like maraviroc. So in adults and adolescents, there is a fixed dose combination. If it's contraindicated or not available, following can be used. So first fixed dose combination is used. Okay. If they are not available, then we use the other fixed dose combination. So AZT can be considered only if HB is more than 8 gram per deciliter. If the patient is on AKT, don't give nevirapine. These are some indications mentioned. So these are the common ADRs and commonly used antiretroviral drugs. NRTI is called cause mitochondrial toxicities. NNRTIs all can cause rash, most commonly caused by nevirapine, generally mild and self-limiting. Protease inhibitors have issue with GI tolerance, altered taste, abnormal liver functions, and bone disorders. All have been associated with metabolic abnormalities such as hyperglycemia, insulin resistance, increase in triglyceride cholesterols, and body fat distribution or lipodystrophy. So nevirapine-induced SJS and zidovudine-induced longitudinal hyperpigmented band in thumbnail. What is immune reconstitution inflammatory syndrome? So this is paradoxical deterioration of clinical status of a patient on ART despite of satisfactory control in viral replication and improved CD4 count. How does it occur? Inflammatory response towards previously diagnosed or incubating opportunistic pathogens, as well as response towards others as yet unidentified antigens. When the immunity was low, the immune response was not that much to these pathogens, but when the immunity starts rising, the immune response starts to pick up and affect and or starts to take action against these commensals or opportunistic pathogens. Frequently occurring cutaneous iris events include TB, herpes simplex, and herpes zoster. An appearance of opportunistic infections within a period of 8 to 12 weeks after initiation of ART should be identified as iris. The risk of development of iris is more if CD4 percentage at the time of initiation of ART is less than 15%, and those who have a more rapid rise in CD4 count after initiation of ART. The rapid rise should be taken into consideration. Now, post-occupational exposure prophylaxis. The healthcare personnel come in contact with blood and body fluids of HIV infected cases, thereby are at a risk of potentially contracting HIV. The risk of HIV transmission due to occupational exposures is given below. The risk of HIV, hepatitis B, and hepatitis C transmission is relatively higher. PEP with ART initiated as early as possible within 2 hours and not after 72 hours can protect healthcare professionals. Early initiation of ART is advised as early as within 2 hours of contact. So this is a diagram representing the same. Now, PP recommendations for adults. Fixed dose combination which is available as a single drug. A single drug has all 3 of the fixed dose. So 1 tablet should be given immediately within 2 hours of accidental exposure. Plus lopinavir or ritonavir, 2 tablets fixed dose dose combinations twice daily. All regime should be continued for 4 weeks. If lopinavir, ritonavir is not available or cannot be used, tenofovir and lamivudine and efavirenz, 1 tablet OD can be given. These should be continued for 4 weeks. Now, post and sexual exposure prophylaxis. Post sexual exposure prophylaxis, the principle is same as PEP. It can be used in case of sexual assault, unprotected sexual contact with known HIV positive partner. Sexual exposure prophylaxis. Administration of ART to an uninfected person before potential HIV exposure to reduce the risk of infection and continued during risk. The regime is tenofovir plus emtricitabine. No consensus about initiation and duration is made. It is effective if taken daily. It does not offer protection against other STIs, and it is not the option for standard protective measures. HIV prevention, safe sex, safe blood, and universal precautions in hospital setup. So safe sex, there is ABCs of primary prevention in sexual transmission. A is abstinence before marriage, B is be faithful, so monogamous relationships with single partner, and C is condom use, correct and consistent use of condoms. There is resistance to use male condoms. Need of the hour is available of female driven protective devices like female condoms and vaginal microbicides. Female condom is a pre-lubricated polyurethane sheath, which is also represented in the picture, with covers which covers introitus in toto, and it is available as well. Blood safety. So blood donation from a volunteer donor is ideal when needed. It must be tested again for HIV, hepatitis B, and hepatitis C virus. Universal precautions should all be taken. Clean habits, common sense prevents HIV transmission. Only one person in the world can protect you from HIV, and that is you. Moving towards the HIV cure, vaccines, neutralizing antibodies, and even stem cell transplantation are also being considered. Main barrier is sterilizing cure, is the presence of latent reservoir. A population of HIV infected cells, those persist for a lifetime despite ART, lack of HIV specific immune response. Eliminating the viral reservoir makes the latent virus susceptible for ART. Allogenic hematopoietic stem cell transplantation from a donor homozygous for HIV resistant CCR5 delta 32 mutation. These are the various ways in which we can cure HIV. Alteration in the host genome using genetic engineering techniques, kick and kill, also known as shock and kill, altering the immune system for better clearance of HIV infected targets. Hit early and hit hard. Treatment in early stages of infections are some of the strategies to be discussed. Now the vaccine, only way to end HIV epidemic. Challenge is genetic variability and the mutagenicity of the virus, its ability to quickly establish a persistent lifelong infection. There is innovative strategies to design vaccines, immunogens capable of activating both arms of adaptive immune response, which is antibodies and T cells. B cell immunogens that stimulate B cells to generate broadly neutralizing antibodies against the virus are now in clinical trials. T cells immunogens intended primarily to elicit broadly reactive, potent antiviral T cell responses against the viruses. Now, innovative vaccine delivery technologies, recombinant vesicular stomatitis virus vector that incorporates the HIV gene envelope is also being used, and to use mRNA to direct cell to make proteins that will elicit immune response against HIV. Thank you.